And we go to the so as Jean just pointed out, we in Maryland are under a unique system called the total cost of care model. And under this model, our state is focusing on reducing costs and improving the quality of care in both hospital and non-hospital settings. Historically, Maryland physicians have largely remained on fee-for-service and haven't been eligible to participate in national Medicare value-based payment programs. So because of this, we wanted to set up our own programs in Maryland because we believe specialists have tremendous potential to drive value and really create system savings. And so it's with that idea that EQIP was born. It's our first specialist focused program really designed to help achieve both cost and quality goals outside of hospital settings. Next slide. So when we talk about a value-based payment, we thought it would be helpful just to sort of level set on what we're talking about. So ultimately, when we are talking about any kind of value-based payment model, really the idea is to get more value out of the system by using the reimbursement methodology, moving away from fee-for-service to really affect cost and quality. So there's three different ways this can actually work out. In scenario one, you could have an improvement in quality and cost stays the same. That may be perceived as a more valuable outcome. Or you can keep quality the same, but you reduce costs. And then finally, the ideal scenario is where you have an improvement in quality and a reduction in cost. And we believe that this is the ideal scenario, and that is what we are trying to achieve with EQIP. So next slide. So with that being said, we wanted to talk a little bit about what you will hear in today's session on EQIP. So this is a voluntary program based on an episodic incentive payment structure that we have created for specialists in Medicare. And the idea is that there are four key features of EQIP that we really want to emphasize, and you'll hear us talk about these throughout the presentation. First, this is a physician-focused program. So the physicians in this program will own their performance, they will monitor their performance, and they'll be able to really have a number of tools available to be able to really understand how you're doing in the program as you move along. Second, we've designed this to have upside only risk with this savings accountability, which makes it easier to perform or to get involved in these initial years, to participate, to be a part of the program, really with only the upside risk or this savings accountability being a part of the design. Next, we have been deliberate to design this program to align with Care First and their episode payment program, really as a way to make sure that it's easy for specialists to participate. So there will be similar designs and approaches to make administration easier for all of the participants. And then finally, it gives specialists the opportunity to participate in an advanced alternative payment model where participants become eligible for the 5% bonus if they achieve quality and savings goals. So all of these components are part of the design that we have put together in this program. We will be using what's called a Prometheus episode grouper. That is the tool that will help us identify the particular episodes that will be a part of the program. And in our first performance year, which is 2022, we will be focusing on the episodes that you see, or the episodes in the specialties that you see listed on the screen. So gastroenterology and general surgery, orthopedics and neurosurgery, and cardiology. And so this is our starting point, and certainly we'll be building upon those areas in future years. Next slide. Really at a very high level, we see this program, or we've designed this program as a bundled payment program because we know that they are very effective at controlling episodic care and quality outcomes, both or rather cost and quality outcomes. And so we've seen this across the country. We've seen that, when you look at CMS programs, they have very similarly designed programs, bundled payment programs that ultimately yield 4 to 6% reductions in gross Medicare spending. And so we have sort of embraced that concept and tailored it to the state of Maryland. So there are three main elements that you will hear about today. First, to start, physicians will agree to an episodic-based payment. So there's a process we'll talk about that will get you enrolled in the program to accept this type of reimbursement model. Then the costs for episodes that you sign up for are calculated for a baseline period to identify an appropriate target price. And so you're being compared to yourself for a baseline period. And then third, performance year costs are compared to that target price to identify whether or not savings and quality goals were hit for the purpose of determining incentive eligibility. And so this is in a very high level, that is the way that this process will work. Next slide. And just to reiterate the point that I made earlier, we are looking at this program as a way to align with other programs that many specialists across the state are already participating in. So to start, we are working with Care First to align our episode program definitions so that their programs and our program have really similar designs and incentives and episode definitions so that, again, it's easier for you to administer, easier for you to participate. And so in particular, both Care First and this program will be focused on using the Prometheus episode definitions. So that's the underlying system to discern or decide on those episodes that get included. We will have separate incentive payments and policy decisions, but they will be really based on the same principles so that there will be commonality across the programs that you are participating in. And then that creates opportunities to receive rewards across both Medicare and Care First. And we hope in future years, additional payers will come on board with these similar designs. So we have been very deliberate to try to really design this in a manner that makes it easy for specialists to participate and understand and manage performance. And so in the coming few minutes that we have together, we will share the details of the program and really invite you to be a part of this process and hopefully sign up to participate when our window opens next month. So with that being said, I'm going to turn it over now to my colleague, Maddie Jackson-Fowle, who is going to talk more about the EQIP design.
Great, thanks. Oh, am I going for others? Sorry.
Yep, you're good.
Okay, great. So as Tequila mentioned, we're going to talk through a couple key components of EQIP. The first piece will be just how participation in our first performance year works. This will start in January of 2022, and we'll walk through exactly how you get in, what the parameters for participation are. So just to level set, we will be using a lot of different acronyms, but as a good roadmap for the next, the next 40 minutes or so, here's some roles and definitions of the different players essentially in the EQIP program. So the first piece is a care partner, and what a care partner is in EQIP is a specialist physician. These are the physicians who are actually triggering the episode, performing EQIP care interventions, and really driving the care transformation within the program. These specialty physicians will also be required to kind of sign a standardized care partner arrangement or contract with a CRP entity, and we'll talk a bit about that more. And they will also receive their normal fee schedule payments from Medicare and a potential incentive payment with the EQIP entity. So essentially, you will bill and receive your revenues from Medicare as normal. However, there is an additional bonus opportunity or incentive payment available at the Maryland state level, which EQIP provides. Lastly, care partners in EQIP are eligible to get QPP status through an advanced alternative payment model, and we'll talk a bit more about that, but that's a CMS or federal benefit that EQIP can also provide to Maryland physicians specifically. The next role that we'll talk about is the EQIP entity. This is essentially a collection of the individual or multiple care partners, essentially the group that you would like to participate with. This can be any collection of physicians. It can be two groups mixed together. It can be half of your physician group, really any collection of care partners that would like to participate in the program. This is the level at which performance evaluation occurs. So we will assess your performance in the program at the EQIP entity level, which is the compilation of all the care partners who join. Additionally, this is the level that the incentive payments will be paid out in a lump sum. So there will be one incentive payment paid to each EQIP entity that the EQIP entity will then be responsible for determining distribution to each individual care partner. The next definition that I want to walk through is the CRP entity. This is a Maryland hospital that will sign a standardized form contract with all care partners or individual physicians in the program. This function or this hospital will be playing a purely administrative function, and they are responsible for both signing the contract with each care partner, but then also paying incentive payments to the EQIP entities based off of performance. And then lastly, we have the HSCRC and CRISP. This is really where the bulk of the policy and the management of the program is driven. We will be responsible for calculating episodes, monitoring performance, determining the incentive payments due out to each EQIP entity. And then we will also maintain any reporting and monitoring requirements on behalf of participants to the federal government or CMS. We will also facilitate that enrollment process between the EQIP entity and care partners, and then also any learning systems, anything to really make our physicians in this program succeed, we will be running out of CRISP, which is our health information exchange at the state. So this is pretty much the overlay of roles. I'll talk a bit more about how these interact with one another. But I did want to also note that we are allowing
So, Maryland.
Oh, sorry. I did want to also note that we are allowing administrative proxies in the program. So essentially, EQIP entities can delegate the management of their program participation to another non-physician source. So it could be a practice manager, it could be a larger system that you are a part of. It could just be an administrative role within your own practice, or it could be an external consultancy or kind of quality improvement contractor. So in order to participate in the program, you have to kind of hit 3 buckets of qualification. The first is that you have to qualify as a care partner with CMS. And what this means is pretty basic. You essentially have to be enrolled in the Medicare Provider Enrollment Chain and Ownership System, or PECOS. You also have to be up to date in PECOS. So a lot of times physicians will have signed up with Medicare initially in their career and not update this PECOS, and this is often an easy snag that we can catch right away. So if you're interested in joining EQIP, I would highly encourage you to update your PECOS enrollment, or just make sure it's up to date with how you're currently practicing. The second piece of qualifying with CMS as a care partner is utilizing CERT or CRISP, our health information exchange. This is required of all participants in an advanced alternative payment model. And it's also just a great resource that we have as a state to have CRISP operating a statewide health information exchange. The second bucket that we require is actual enrollment in EQIP. And we'll talk about the system that we're building out to help facilitate this enrollment. But there are a couple key components to actually enrolling in EQIP. The first is that you have to establish who will actually be in your EQIP entity. This can be multiple care partners or multiple NPIs or different providers in any grouping that you see fit. It can also be one individual NPI should you choose to participate in that way. The second piece of enrollment is that you will be required to select episodes and interventions and then agree to our quality metrics. So you will be able to see your opportunity in each episode, and you will be able to select or tell us which interventions you intend to deploy in the program. The next piece of enrollment is signing that care partner arrangement. This will be a standardized contract statewide for all physicians, and it will be required for participation in the program. And then the last piece is your EQIP entity will have to determine where the payment or the incentive payment you will actually be sent. There's one singular payment remission recipient for EQIP entities. And so that lump sum has to be directed to an entity or a business address. The next piece is that the final piece is that you have to meet episode thresholds to participate in EQIP. So what this means is you have to provide care to Maryland Medicare beneficiaries. And for a single episode of participation, you need to meet at least 11 episodes in our baseline. So say you want to participate in the colonoscopy episode, you have to have provided more than 11 colonoscopies in the baseline to participate. Across all of your episodes of participation, you must meet a threshold of 50 episodes in the baseline. So for your EQIP entity or your collection of physicians, you must have at least 50 episodes in the baseline. So say your EQIP entity chooses to participate in colonoscopy and endoscopy, and that sums to 52 episodes, you would be eligible to participate in the program. In terms of the interventions that we expect in EQIP, we will also require you to report to us or kind of indicate what you intend to deploy. We think about the interventions in three main categories. The first is clinical care redesign and quality improvement, and this can be anywhere from implementing more standardized evidence-based protocols, for example, discharge planning and follow-up care. This also can mean performance of medication reconciliation pre or post-op. It could also mean that you're looking very seriously at the services providing and eliminating any duplicative or potentially avoidable complications or low value services that aren't necessary for the episode. In the second bucket, we look at beneficiary and caregiver engagement. So these interventions can range anywhere from patient education and shared decision-making, maybe implementing more health literacy practices or more patient education pre-op into your typical routines of care, really anything that will help the patient succeed or have better outcomes in the long term. And then the third piece is care coordination and care transitions. Again, this can range, but we're looking at things like assignment of a care manager or thinking about enhanced coordination to follow patients across settings, from pre-op to post-op to say if they need some sort of skilled nursing facility, that sort of thing. This also could include implementing interdisciplinary team meetings. So that way you can really address patients' progress and really get all facets of the patient down. And then the final piece is a selection of the most cost-efficient or high-quality settings of care. So a part of EQIP that we'll talk about later is the fact that the target pricing is not based on the setting of service. It's actually neutral to where the service is provided. And so in that way, we want to open up incentives for physicians to think about what the acuity of the patient is and does that match the acuity of the setting chosen for the procedure. So as I mentioned, there will be a CRP entity that is uniform across the state. For EQIP, we are utilizing the University of Maryland Medical Center. And this is really to help us enable the program as an advanced alternative payment model with CMS. What this means though is any physician in Maryland will be able to participate in EQIP regardless of any previous or current contracting relationship or privileges at University of Maryland Medical Center. What they will be doing is playing a purely administrative role, which is really signing that individual care partner arrangement, which again will be standardized across the state and written by the HSCRC at the state level. And the second role will be essentially printing the actual checks to pay out the incentive payments to the EQIP entity. So that means the HSCRC will tell University of Maryland Medical Center how much is due to each entity within the state. We as the state will facilitate all interactions between the University of Maryland Medical Center and care partners and EQIP entities. The policy decisions and operations and performance evaluation remains at the state level, and any changes to the policy will be made in a transparent stakeholder process. So really what we're trying to get across here is this is a purely administrative function and it helps us to enable EQIP as an advanced alternative payment model, which is very important for getting those QPP bonuses and some other privileges from CMS. but University of Maryland Medical Center will not retain any control or kind of discretion over the way that the policy is administered. And just to talk through a bit more of those operations with the University of Maryland Medical Center, they essentially will receive 3 pieces of data during your performance time. They will receive a list of care partners who have been submitted to CMS for vetting, and this will be essentially a list of people that they must execute contracts with. The second piece is they will be able to see who has formed an EQIP entity and where they would like their payments sent as an organization. And then the final piece of data that they will receive is a final incentive payment list, or kind of what is due out to each EQIP entity. And those are kind of the dates and timelines for those 3 pieces of information in those top 4 bullets. The CRP entity will not have any access to your protected health information or patient panels or patient files. They also will not have access to any EQIP entity or care partner performance analytics. Again, this is a purely administrative function, so that way we can execute contracts and send payments under an advanced alternative payment model. Any program data, inquiries, and policy procedure, again, are managed by us at the HSCRC and CRISP, and this includes operations and interactions with the CRP entity or University of Maryland Medical Center. In terms of a timeline for participation, this will be an annual participation opportunity open from July through September of each year prior to the performance year. We may update and increase participation opportunities year over year through our stakeholder engagement process, but I think everyone on this line is very lucky in that gastroenterology has been included in the first year of performance. So just looking at this chart below us, we will utilize a 2019 baseline trended forward that kind of removes any of the dynamics of 2020 and any kind of off year elements that we might have experienced due to the pandemic. The first performance year will be in 2022. After the end of the performance year in December of 2022, we will wait 3 months to ensure all claims have appropriate time to come in. And then we will kind of cut incentive payment checks or determine incentive payments due by July of the following year. From July to September of the next year, performance will open again for participation, and we will follow that schedule thereafter. So in terms of what's available for gastroenterology in the first performance year, here's a list of the overarching episodes in the left-hand column with the type of episode that they are. For gastroenterology, they're all procedures, and the length of the episode, which is essentially the amount of time that we will count and collate claims to be included in the total cost of that episode. So we have colonoscopy, colorectal resection, gallbladder surgery, and upper GI endoscopy. So endoscopy and colonoscopy have a shorter window for counting costs, and we'll talk through how we specifically do that. And then colorectal resection and gallbladder surgery are 90-day episodes. The right-hand columns are the triggering procedures or the specific CPT codes, descriptions of what will actually trigger an episode, so that way you can get a sense of what's included in these kind of more overarching buckets of episodes. And on these definitions, we're happy to talk through offline more specific questions. We also are developing an episode playbook, so that way everyone can really understand how the episodes are triggered and then how costs are declared relevant to the episode and pulled into the total costs. In terms of just total scope of the program, we are seeing about 34,000 statewide episodes or statewide procedures in gastroenterology in the first year. For unique NPIs or unique physicians, this is about 2,400 different NPIs. The average cost of these episodes ranges obviously on the bit higher side for something like a colorectal resection and about $1,600 for that colonoscopy episode. When we look at total cost statewide, this is really where we see the savings opportunity that we can share back with specialists who help to provide those savings to the state. So if we look at the total cost included in this episode, we see about $140 million statewide being spent in these areas. If we assume kind of a more conservative savings rate of around 3%, we would see a savings opportunity of around $4.2 million. That $4.2 million is something that we as a state can share back with you guys as specialists for creating that value in the system. And that's what we would like to pay out on incentive payment. So I'll chat through how we determine that share, but essentially it's not only an opportunity for the state, it's an opportunity for specialists to receive bonus payments or incentives on the hard work that they do to drive value. So now we'll move into kind of how we determine, what goes where and those incentive payments and how those will be paid out. So first, I wanted to kind of bifurcate where each EQIP policy methodology are determined. So there are two main buckets that we see things in. The first is the Prometheus episode definition. This is an algorithm or a grouper that is developed by an external resource to the state. We'll talk through that a bit, but this is really where the episode definitions and triggers have been developed. They have standard definitions that are used nationally that have been developed over a series of time by both clinical and coding experts to ensure that they are pulling in all relevant costs to these procedures and episodes. And that brings me to the second piece, which is the relevant cost methodology. EQIP takes a bit of a different approach to counting costs connected to an episode and really takes a more exact approach to really counting only items that are relevant to the procedure of interest. So once Prometheus kind of builds out the episodes, builds out the costs, we then move it to the right-hand side, which is the HSCRC and CMS policy. This is where we will determine how your target prices are set, what the shared savings and incentive payment methodology is, what quality metrics or quality adjustments will be applied to those incentive payments, and how the reporting and monitoring and participation in different specialty areas will work. Additionally, CMS policy is where we dictate that QP status or the advanced alternative payment status, but the HSCRC works very closely with CMS to ensure that we get the best participation opportunity with our specialists. So just a bit on the Prometheus episode grouper. This has been an iterative development since 2006. It was first maintained by HCI3 and Alterum and recently acquired by Change Healthcare. It is a proprietary algorithm, though it has been disseminated in national commercial programs since 2006. What really excited us at the state about Prometheus is that it promotes coordination and collaboration across the continuum of care at the specialist level. So I think we've seen a lot of other models where there's a more blunt approach taken to pulling in total costs. And what excited us about Prometheus is it really tailored it to a specialist level of care where you're not in a primary care type role, you're not responsible for the whole spectrum of care, but there is a very specific episode of care that you can impact outcome and quality on. In Prometheus as well, there are 97 different episodes. If you'll see, we only included 4 for gastroenterology, and we have a couple others in our specialty areas of interest, but we mostly focused for the first year around anything that was procedural and acute, though there are other episodes around chronic disease and other episodes around mainly focused on cancer and pregnancy. So the way that it basically works at a very basic sense is that there's a triggering event, which is either a procedure, a surgery, or an acute event occurring, as determined by the CPT codes I showed you a few slides back. Then from that triggering event, the algorithm essentially goes and looks up all of the claims in the post-trigger period for the set duration of time. So for colonoscopy, that is 14 days into the future. So it will follow that patient and collate and pull in any claims that have services relevant to the episode. And they tag these via ICD-10 codes or kind of relevant diagnoses. So for example, this could include post-acute care, any skilled nursing care, any post-op or follow-up care that is deemed clinically relevant to that colonoscopy happening. The other thing that the algorithm does is from the date of the triggering event, it will look backwards. So it will look at a pre-trigger period, usually about 30 days, to capture any pre-surgical care. So this means any blood work, any labs, x-rays, office visits that are related to that episode will then get pulled into the total cost so that we can build a total episode cost. So from here, we kind of pull these out and we call these the relevant episode costs. So any relevant costs to the episode are included in that target price and your performance assessment. The way that Prometheus really pulls in the relevant cost analysis is it starts from a total cost of care basis. So I spoke a bit about, some past programs have used a more blunt mechanism. Total cost of care is essentially pulling in anything related to that patient for a set duration of time. Prometheus, as I said, goes a step further and then goes and excises only costs relevant to episodes. So relevant diagnoses, relevant services, really anything that's tagged back to, say, that colonoscopy. From there, it really falls into two main branches. The first is the cost of all typical care, which are basically provider practice patterns and things that you already do as a provider, typically around those around those procedures. This includes core services and also routine services that you specifically as a provider might already be providing. Where we really see the opportunity that Prometheus helps us to identify is in these two green buckets. So the first is overused services and setting selection. Prometheus will be able to provide us some insights into what services in your patient panel might be getting overused, or it might be an opportunity to reduce in order to reduce the cost of care. Additionally, Prometheus will provide insights on setting of care and whether or not some lower acuity episodes may be more appropriately shifted elsewhere. The other thing that Prometheus provides us insight on is the cost of all potentially avoidable complications. And these are on an episode specific level. So the algorithm essentially goes through and tags anything that is potentially avoidable, that is a complication that's potentially avoidable, and will provide insights back to providers so that maybe there can be more preemptive or proactive care provided in order to prevent these things. So what I like to say is, we really don't see the benefit and the core value of EQIP being in, shifting office visits around or changing your typical provider practice patterns, but more so the insights that we can get from this episode grouper and then deploy into your actual practice day to day. So now we're moving into the right-hand side, which is once the episodes are built, once we get them out of the grouper, what happens to them and how does the HSCRC really determine if an incentive payment should be earned? The first is that we will look to set a target price. So to set the target price, we will utilize a baseline. We will look at baseline costs for 2019. This will serve as a baseline for the first 3 performance year for EQIP entities who join in year 1. If you join later than year 1, it will be the year prior to you entering the program, again, holding stable for 3 following years. Each EQIP entity will have their own unique target price per episode. So that means it will be tuned to your historic patient and case mix. The baseline will also be trended forward or inflated forward, so that way we can have a more comparable real-time assessments that accounts for inflation in the current performance year. So what this means is that the target price isn't really final until the end of the performance year, as inflation throughout the end of the performance year we will not know. However, what we will do is we will provide some idea in real time of your target price versus your performance costs. Though we do want to note that those target prices are not quite final until the end of the performance year. Additionally, something unique for EQIP is that each episode will have a singular target price, regardless of the setting of care. So that means across your hospital, outpatient, and ASC type procedures, the target price will be blended to reflect your historic case mix in those areas. The reason for this is that we think that we know the gap between, say, an ambulatory surgery center and a hospital is significantly larger under the Medicare fee schedule in Maryland, partially due to our rate regulation system and our total cost in our model under GBR. What we want to do, though, is really align the physician procedures with GBR incentives or hospital incentives, which are to really reduce unnecessary utilization and shift those lower acuity procedures to lower cost settings. So we really want to create alignment among both the physician reimbursement and the hospital reimbursement to think through what's the most valuable setting of care for patients. So once we get a target price set, we will then kind of go into incentive payment methodology and really determine how much should be paid out to each EQIP entity for their performance. So the way that this works is we will look at your performance period results in the aggregate. So we will look at your performance period results as an EQIP entity and determine if the performance period costs are less than the target price set for that year. If at least 3% of savings are achieved, we will start to pay out or think through an incentive payment. And I do want to note that this 3% of savings achieved is just a statistical significance check. We will pay out first dollar savings achieved should they be there. So we essentially go in and say, yes, we're 3% of savings met. If so, we will start to pay out 100% of the savings achieved. So once we determine savings were achieved, we then push this into our shared savings calculation. So we will determine shared savings, or the share of the savings that earned by the EQIP entity based off of a statewide ranking on relative efficiency. So what this means is our higher cost providers will be placed in a lower rank, and our lower cost providers will be placed in a higher rank in the state, or a higher percentile. What we're trying to do here is really reward those who have already met a relative efficiency in the way that they provide care by paying out more shared savings to those providers, and then incentivize maybe higher cost providers to improve more rapidly so that way they can achieve higher shares of savings. However, we will pay out shared savings to all participants regardless of how they rank in the program. So in that first tercile from 0 to 33rd%, we will pay out a 50-50 shared savings of any savings achieved in the performance period. The second tercile from the 34th to 66th percentile, we will do a 65-35 split of the savings achieved. And then that highest tercile of 66th percentile, or our lowest cost providers in the state in the episodes, we will pay out an 80-20 split. So we will pay out 80% of the savings that you achieve, and that's 100% under the target price. So once we determine your split from the shared savings, we will then move into the clinical quality scoring. So to be eligible as an advanced alternative payment model, EQIP will have to have a quality adjustment. Additionally, we as the state think cost savings are good, but as Tequila mentioned on that earlier slide, we think cost savings with quality improvements are the best case scenario for us. So we will withhold 5% of your final incentive payment to assess quality and pay back what you've achieved on your quality metrics. Your performance on specific quality metrics will indicate the portion of this withholding that you can essentially earn back. So say you scored in the higher percentile of our quality scoring, you would earn back, say, 4.5% of that withholding. Essentially, it's a scale based off of your performance on quality. Once we then do that quality adjustment, we will go do another check to ensure that you are not running up against an incentive payment cap. What we do here is we ensure that the incentive payments that will be due out are no larger than 25% of your EQIP participant of your EQIP entity's prior year Part B payments. So essentially it's a stop gain at 25% of your total Medicare Part B revenues from the prior year. And then finally, we will pay out that incentive payment. We will directly communicate it within CRISP what you are due. And this is a final lump sum payment that will be paid directly to the source that was indicated by your EQIP entity. We will pay this in full 6 months after the end of the performance year. So back to that slide with the arrow and blocks, that's about July of 2023 if you participate in 2022. In addition to this lump sum incentive bonus payment, you will also be eligible for quality payment program status with CMS or with the federal government, and Medicare will pay a bonus to you as a physician and give potential rate increases in future years for participation in this advanced alternative payment model. And we'll talk a bit about that as we move along. So just to walk through an example of this incentive payment calculation in the aggregate, essentially what we will do is we will look at line A, this participant is in episode A and in episode B. We will assess your baseline period episode costs or your benchmark, and then we will trend them forward for inflation to determine your episode target price, or line B in this example. For the purposes of this, we did not inflate, so please pretend inflation is there. And so from there, we'll then go look at your episode volume in the performance year, and then the episode costs for the performance year. So here we'll see in line D that compared to line B, it looks like there's about $700 of savings in episode A and $500 of savings in episode B. We will then go and aggregate the performance year episode costs by multiplying the volumes by the actual episode costs. So line E shows that aggregate kind of accounting. From there, we will compare that back to a baseline. Would those volumes have been similar? So in both of these cases, we see about a $17,000 and $25,000 aggregate savings on each episode. We would then perform that 3% check just to make sure that there's statistical significance in the savings achieved. In both of these cases, that is the case. So then we would move to kind of paying out that tiered shared savings rate. For purposes of this example, this participant is in the 73rd percentile rank, which means that they are due 80% of the shared savings to their EQIP entity. So applying 80% to 17,000 and 25,000 together gets us a total incentive payment of about $34,000 due back to the EQIP entity for their participation in EQIP. And we'll also note that there should have been a quality adjustment in there, but this is easier for demonstration purposes. Okay, so one key component that we have not mentioned about EQIP is, yes, it's an upside only risk program with no downside risk collection back from providers. However, we do want to create some savings accountability in the program to ensure that we're really driving meaningful improvements in cost efficiency and quality. We will not, again, collect downside risk, and we will not directly adjust your fee for service or your Medicare revenues. But we did think it was important to keep some sort of accountability within the program to ensure that everyone is approaching this value-based payment with the same fidelity. So in lieu of downside risk, our savings policy will help to ensure outcomes in two different ways. So the first is that we will create we will take any savings created in a prior performance year and require those to be offset by the EQIP entity in the following year prior to earning a reward. So say there was a $5,000 savings carryover, but you're due with $30,000, you created $30,000 of savings. We will then reduce that $30,000 to $25,000 to account for prior year savings. The second piece of this policy is that we will remove EQIP entities from the program altogether if they're in the lower two terciles, so those higher cost providers, and they've created 2 consecutive years of savings. Our reasoning here is that we are being qualified as an advanced alternative payment model with CMS. And so we don't want that to be the only reason that providers sign up. We do want to actually see some results on cost and quality at the state level. The reason the third tercile is kind of left out of this bucket is that we feel these providers have already reached a relative efficiency. They are our lowest cost tercile. And therefore we do want to kind of keep one incentive to continue in the program, especially since savings will be harder to achieve. So that is that QPP kind of bonus status. We are committed to monitoring the effects of this policy and ensuring that there are no unintended consequences as a state. Obviously, since it requires 2 years of savings and the program hasn't started quite yet, we can't tell what the actual impact and outcome will be, but we will maintain this in a transparent stakeholder process. So rest assured, it won't be an immediate or kind of surprising dynamic for participants. Additionally, as we've mentioned a couple times now, EQIP will be an advanced alternative payment model. So this means that participating care partners can qualify into QPP in the advanced alternative payment model track. This really benefits, I think, Maryland physicians in a couple ways. What it means is that there's a potential 5% increase or incentive payment on top of your Medicare revenues paid out by the federal government. So this is in addition to the EQIP bonus payments that we are offering, a 5% essentially bump in your Part B payments from Medicare. You will also be excluded from any MIPS reporting requirements and from any payment adjustments that are mandated under MIPS. So you're essentially moved out of MIPS into an advanced alternative payment model track. The way this will work is that if you participate in 2022, you will receive a lump sum payment from CMS, that 5% bonus to your Part B payments, in 2024, based off of your 2023 revenues or Part B services. So essentially, you get into the program in 2022, that counts as your participation, then they start accounting in 2023 to be paid out eventually in 2024. So essentially saying here, not get in now, but there's a little bit of a longer horizon on this payout, though it is significant and a great opportunity at the federal government. And so 2022 participation will actually benefit you up into 2024. For initial performance years as well, any beneficiaries kind of touched by a care partner or treated by you as a physician participating in EQIP will be attributed to our advanced alternative payment model. So some of those more traditional QPP thresholds will be a little bit easier to make should you participate in EQIP. Additionally, I mentioned that there will be a quality adjustment for EQIP. For the first performance year, we wanted to focus on utilizing the same measures across all of our specialty participation areas. And we really honed into this on kind of 3 areas. The first was looking at the measure characteristics. Are these measures applicable at a physician level? Are they something that are vetted by the federal government and really adopted in a widespread manner? Additionally, are these measurable off of Part B claims? We really wanted to reduce any sort of reporting or submission burden by our participants. And so the fact that the measures we've selected are measurable off of Part B claims mean that you will not have to submit anything essentially for quality measurement. We at HSCRC will be able to do it. The second piece is we had to maintain some fidelity to QPP or CMS standards. We wanted to ensure that the measures we were selecting were high priority or outcomes measures, and that there were at least 3 measures available to be applied to all participants. And then finally, at the HSCRC, we have our own priorities to add on. We wanted to ensure that these align with Care First and what they're doing in their program as appropriate. We also wanted to ensure that the episodes were agnostic to, or the measures were agnostic to the episode type. We did not want to have different measures for each episode in this initial performance year. And then finally, we did want to tie this into our larger population health strategy, which is our statewide integrated health improvement strategy. And this is really a forceful mechanism to ensure that we're all aligned in what we think about when we think about where we should improve on population health. So for the first performance year, the 3 measures will be an advanced care planning, documentation of current medications in the medical record, and preventative care and screening for BMI. All great things that are important for patients at some time in the continuum of care to ensure that they can safely undergo procedures. Again, this quality adjustment will be to the final incentive payment after shared savings, and it will be kind of a 5% earn back. So you will be eligible to earn up to 5% of your total incentive payment back. I also do want to mention that for each episode that is triggered for you, we will assess if the 3 measures were performed a year prior to the end of the episode by any physician. So this does not mean that there needs to be a significant change in your practice patterns, although these are all billable services eligible for all of our specialty areas. What we want to ensure is that there is coordination with other parts of the care continuum. We want to ensure that there is coordination with that primary care office. There is a utilization of CRISP to make sure that these activities are done, and that there is, some, kind of eye on these process items getting done and put into place prior to a procedure actually occurring. So I'll move on, and I will turn it over to my colleague, Jessica Hislop, who is our CRISP program manager, and she's gonna walk us through the EQIP entity portal, which I like to lovingly call the TurboTax of EQIP. So Jessica, take it away.
Thanks, Maddie. And that's a great analogy. As everyone hopefully is aware, CRISP is the designated HIE for the state of Maryland. And along with our partners at H-Metrics, we've developed the EQIP entity portal, EAP, it's a nice way to remember it, which is where participants will be able to enroll, to look at baseline data. They will ultimately be able to go back to this portal once performance data is available. And it's really that one-stop shop where everything can be consolidated and viewed within one unique place. So as mentioned, lead physician can select an administrative proxy within this portal and also designate if they would like to join as an individual or as a group. This is the venue in which that EQIP entity would be established. Throughout the enrollment process, there'd be full transparency as far as the status. So you'd be able to go into that portal, determine where you are from your care partner agreement. Has it been signed? Does CMS have, is there any feedback from CMS as far as your vetting status? If there is an issue, we would again provide that feedback there and hopefully work together to get that squared away prior to the enrollment start, or sorry, for the program start. And then also upon selection of your NPIs and your episodes, you'll be able to see that baseline data and view opportunity analysis. And finally, once the program goes live come January 1st, around March, the performance data will be available and updated monthly. So there can be an ongoing tracking of how everyone's doing. And again, that upfront transparency as far as expectations of incentive payments if earned. Just a note, the EAP or the EQIP entity portal does live within the CRISP reporting services suite. And this is something that is a unique access to each organization. So if you are not sure if you have CRS access, please reach out to equip@crisphealth.org. We can determine if you have access now, which will help speed up the process and allow you to access the portal when it goes live July 9th. And also access is granted at an individual level. If you choose to join an EQIP entity with, let's say, 50 physicians, not all 50 physicians need access. Simply your lead provider and one or multiple administrative proxies, if you choose, would have access to the portal and be able to view that information and help streamline any data that's needed to be in, as well as communicate data that's shared back out. So again, if you're not sure of your status, simple way is email us at that equip@crisphealth.org, and we can check on your status and give you the appropriate next step to make sure you're ready to go for our July 9th start.
Thanks, Jessica. And I'll also mention that Jessica is going to host a series of great webinars that will really walk you through how to use the portal, get everything ready for sign up on July 9th. When the portal opens, and so that way everyone's ready to go. And we're less talking in the abstract, but it's a really great tool and resource that CRISP has developed for us. Okay, so we're nearing the end here. Here we go. And so I just wanted to quickly kind of, touch on and close out what we really see the benefits of EQIP are as a state. I think we are incredibly lucky in Maryland to be able to design our own value-based payment opportunities that are tailored specifically to our providers. And this one is the first that is really focused on specialist physicians and the value that they can drive in healthcare here. The second piece is that we do not have downside risk collection in this program. We have some accountability for DIS savings, but there is no direct collection of your fee-for-service revenues from Medicare and EQIP. The third piece is that we really see this as driving system alignment, regardless of the setting of care. So we really wanted to focus on finding a way to align incentives without having to change reimbursement structures and at the setting level. And what we found is, really driving it at the physician level allows us to have the care follow the physician based off of how they practice, which brings me to the fourth really great benefit of EQIP, in that the episodes are tailored to how you already practice medicine. Your target price is your own. It is tailored back to your patient and case mix that is historical to how you've typically practiced. And it really then tailors the episodes back towards the scope of your impact as a provider. And then finally, we at the HSCRC, as well as at MedChi and across the state, are always looking at opportunities to improve patient outcomes and really contribute to our health system improvement. We think finding ways to make the system work better and the incentives align, but then also support physicians as they drive a lot of this meaningful work is a priority of ours. And so we've designed EQIP with that in mind. And Jean,
I guess we can open it up for questions now, right? And
so I do have 2 quick timeline slides or kind of overview. So I'll just quickly go through these and then we can, I think questions sound great, Jean, if that's okay. Yeah, okay. So quickly, just looking at the timeline, a couple key dates that I want to highlight here is we are doing recruitment now. If you or your specific organization would like us to come talk to you or answer any specific questions, please reach out. We're happy to talk. July 9th, EQIP opens for enrollment. So we will have some technical user guides available and also baseline experience in the program available on July 9th. This portal, we will require all of your NPIs and your EQIP entity to be submitted prior to September 1st. This doesn't mean you have to be contracted and choose your episodes by September 1st. We just need to know who intends to participate at a physician level, so that way we can submit them to CMS for vetting. We will then continue on contracting and making sure everyone's up and ready for participation to start in January 1st of 2022. And then performance analytics will start March of 2022 after some time to allow claims to come in a bit. And again, we'll post these slides so they can be a resource to kind of tie back to as you're thinking through your participation in EQIP. So as I mentioned, we are happy to do one-on-one demos and meetings, walk through any opportunity analysis specific to your organization, discuss any episode definitions, answer specific questions. Really, any questions you have, please come to us. We're happy to help. We also have a subgroup or kind of a stakeholder group that we convene every 3rd Friday of the month. The next one is June 18th, and Jean and his team can help you get added to that distribution list if you're interested. And then if you just generally don't know where to go, you can reach out to equip@chrishealth.org. They are excellent navigators for any questions, you know, from Chris to CMS to anything that you might have and you're not sure where to go with it, please reach out to them. And then again, our website at the HSCRC will have up-to-date items. So just some quick updates, but I would love to hear if there are questions and, you know, answer anything that might be helpful to people.
any questions?
Okay, well, we can also answer offline if that's helpful, Jean. But
Yeah, so we can, if anyone, you know, wants to think about it or would like to have a specific meeting with their practice or their group, we're happy to do that. We're doing that for some of the other specialties. But again, I think we're really excited about this because there's no downside risk. You have the possibility of incentive payments under the program. You're getting paid your full fee for service, and after you're in for a year, you have a shot at being in an AAPM. So it seems like it's a pretty cool opportunity for Maryland physicians, and I hope you take a second to look at it or talk to your organization if you're not the decision maker on these things. So thanks an awful lot, and feel free to reach out to me directly, or you can reach out to Maddie, or you can email the EQIP at Chris Health, and one of us will get back with you and try to help you out. All right. Well, good night, everybody.
thank you.
Don't forget to fill out your CME forms.
Take care.
Bye.